Okay, certainly want to welcome everybody to this week's happy hour session. Um, I'm very pleased this week to introduce a dear friend of mine, Dr. Martin Fernandez. Dr. Fernandez is the chief of dermatopathology at Baylor Scott and White and Temple. I've had the privilege of knowing and working with him on and off for about the last 10 to 15 years. He's an excellent dermatopathologist and a top-notch teacher as well. He's the director of a dermatopathology fellowship at Baylor Scott and White, which he started in 2018. Dr. Fernandez is board certified in anatomic pathology and clinical pathology. He did his training at University of Texas Medical Branch in Galveston, and then subsequently did a Surge Path Fellowship at Memorial Sloan Kettering in New York, where he also completed after that a dermatopathology fellowship at New York University. So before I turn the microphone and stage over to Dr. Fernandez, I wanted to let those of you who are attending the session live today know that we will be taking a break next week. It's Memorial Day, Monday, and we'll be celebrating that with our families. And we've got some top-notch speakers lined up for our June sessions. On June 7th, Dr. Lauren Clark with Myriad Genetics is going to be discussing molecular diagnostic testing and tests available for diagnosis and prognosis of melanomas. And a lot of that is cutting edge data. And I know that, it's something those of you who are preparing for your Dermpath core exams and certification exams will want to either tune into live or go back and review once it's up on our YouTube channel. Then on the 14th, our own Dr. Mahoney is going to be discussing alopecias. And on the 21st of June, we'll be very privileged to have Dr. Beth Rubin from Palo Alto in California to be discussing nail anatomy and histologic diagnosis of common nail diseases. She's really a fabulous teacher, and she's one of the country's leading experts on nail diseases. And then finally, we'll be offering our next Dermpath board review for those of you preparing for the core exam or the applied exam on Saturday, the 26th of June. We'll be discussing the answers to the slide decks that we send out beforehand. And again, all of these sessions will be recorded and will be available on our website. So if you have any questions, as always today, go ahead and post them to the chat, or you can send them to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. I just brought up the chat. So I'll turn my camera back on at the end of the session, but I'd like to turn the session over now to Dr. Fernandez. Martin?
Thank you very much, Dr. Davis, for inviting me to host this session of the Dermpath Happy Hour. And welcome, everyone. Today, we're going to be going over 12 cases. These are, there is no theme in these cases, but there is one common theme, which is there are interesting cases, but other than that, they're all, no theme. So let's start with case number 1. In here we have a punch biopsy. And at this power, we can see that there appears to be an area of, or there is an area where it appears to be increased cellularity here in the upper reticular dermis. And as we go in higher power, it becomes apparent that, these are not cells that we are seeing. These are actually elastic fibers. And these elastic fibers are abnormal in that they are kind of short and fragmented. And of course, normally, this is an H&E stain. So on H&E stain, we, do not see elastic fibers. unless there's solar elastosis or unless they are clinically damaged. But normally we do not see elastic fibers, but in this case they are, of course, they are not only visible, but they really are jumping out of the screen here. So, and that is because they are encrusted with calcium. So if we want to confirm that these are indeed elastic fibers that are encrusted with calcium, we can do an EVG stain, which would demonstrate that these are elastic fibers. And then we would do a von Cossa stain, which would prove that they are, there's calcium within them. So, of course, whenever you have these findings, then the diagnosis is pseudoxanthoma elasticum, or PXE. And this can be an inherited condition, or it can also be an acquired condition. And it has been associated with the use of penicillamine. And it has also been associated or, following liver transplants. And more recently, it has been described in association with a number of other inflammatory processes seen, incidentally, maybe not as dramatic and as extensive as we see here, but yeah. So first case, pseudoxanthoma elasticum, or PXE. So let's move on to the next case. Here we have a shave biopsy. And so this power, you can see that there is clearly epidermal hyperplasia. In addition, there is also a lichenoid infiltrate. There's a little hyperkeratosis. And let's take a look. Within the epidermis, you have many necrotic keratinocytes. Notice all of these scattered cells with bright pink eosinophilic cytoplasm and pignotic nuclei. So these are all necrotic keratinocytes. And if we take a look at the infiltrate is composed of lymphocytes with many eosinophils. Also, we continue and we see that there's pretty prominent spongiosis with the presence of spongitic vesicles, and then spongitic vesicles are, have numerous eosinophils. So it's actually eosinophilic spongiosis. And again, you see a little cluster of necrotic keratinocytes there. So this constellation of findings is quite unique, especially if you see these findings on a girl that is weeks old to a few months old. Then, of course, the diagnosis is Incontinentia pigmenti. And again, the key findings here are the presence of numerous necrotic keratinocytes and eosinophilic spongiosis, especially in this clinical context. And I think, as you know, the clinical findings in Incontinentia pigmenti vary quite a bit depending on the stages of the disease. And that's also true, of course, on histology. So remember always when the clinical picture will correlate very well with the histology. So these findings are of the vesicular stage of Incontinentia pigmenti, which will be quite different from the verrucous stage, the hyperpigmented stage, and the atrophic hypopigmented stage. And yeah, so remember again, just to emphasize, scattered necrotic keratinocytes and eosinophilic spongiosis in a very young female patient is Incontinentia pigmenti. Let's move on to the next case. Here we have a bisected punch biopsy. And I have to say that at this power, it looks almost normal. There's nothing that really stands out, except as you start looking at the epidermis a little closer, you'll realize that there is indeed some compact ortho hyperkeratosis throughout the surface of this specimen. Well, it's pretty prominent compact ortho hyperkeratosis. There's no parakeratosis. And there's a little bit of a disconnect here because the epidermis, other than the cornified layer, looks apparently normal. And so usually there's very good correlation between the let's say between the granular layer and the cornified layer. In other words, normally when you have a very prominent granular layer, then you tend to have a prominent compact ortho hyperkeratosis. And you would see that, for example, in Lichen planus or in prurigo nodule, you have epidermal hyperplasia, prominent granular layer, and prominent compact ortho hyperkeratosis. The opposite is also true. When you have absence of granular layer, you tend to have parakeratosis. And then you would see that, for example, in psoriasis. And then you would see that also in like neoplastic processes like actinic keratosis or squamous cell carcinoma. So those things correlate well. And here there's a disconnect because you have prominent compact orthokeratosis, but look at the granular layer. It's pretty inconspicuous, right? So for this degree of compact hyperkeratosis, you would expect prominent granular layer, like you would see again in Lichen planus or in prurigo. But in this case, it's not. So then, you realize that the diagnosis in this case is Ichthyosis vulgaris. And of course, Ichthyosis vulgaris is due to a mutation in filaggrin. And some people categorize this within the category of invisible dermatosis, in the sense that low power findings may be pretty inconspicuous. So that's why it's always a good idea to really pay attention to the clinical description, because whenever you're confronted with a biopsy where you don't know what's going on, you don't know what the main findings are, then you can get a clue from the clinical description. In this case, if they had said patient has increased scale, then you would of course look at the cornified layer. If they talk about a papule, then you would look something in the dermis. So for example, if they talk about a pigmented lesion, you would look for pigment either in the basal layer or in the dermis. Or sometimes it could be clinically, it could be more of a nodule. And like in this case, if they were describing a nodule and we don't see anything, it could be that the lesion was not biopsied or was not sampled because it was underlying all of this. So this a few things to keep in mind for so-called invisible dermatosis. But in this case, yeah, I think we can all see that there is a compact ortho hyperkeratosis. So Ichthyosis vulgaris. Moving on to next case. Here we have another punch biopsy. And this power is probably from the back, because the reticular dermis is pretty thickened, or it's pretty thick. And this power, you can see that the epidermis is, essentially unremarkable. And then in the dermis, we have an infiltrate. So one thing to notice about this infiltrate is the distribution. Normally, when you have in other words, what's a little bit unusual about this infiltrate is that it's not only perivascular, but it's actually mostly interstitial. So the distribution of the infiltrate is going to give you an idea of what the cell type is, because typically, if you have a sparse infiltrate, then lymphocytes tend to just stick around the superficial vascular plexus, or just around capillaries, or even maybe around the nexa, but not so much interstitially. If you have an interstitial infiltrate, then you should think that this is a non-lymphoid infiltrate. Probably, this could be neutrophils or eosinophils or something else. So in this case, if we go on higher power, you can see that these do not look like lymphoid cells. And why are these not lymphoid cells? Well, you see that these have too much cytoplasm for a lymphocyte. The cytoplasm is amphiphilic and is a little bit granular. These have round to oval nuclei, mostly central within the cell, and some of them are slightly spindled, as you can see here. So there's a little bit of a range of morphology, but there's some monotony to these cells, at least in the sense of the cytoplasm. And there's also many eosinophils scattered throughout this lesion. So at this point, again, look at the epidermis, pretty pristine, remarkable. And so at this point, in order to arrive at a correct diagnosis, you can either just recognize the cell type. Of course, you have to realize, you have to figure out what the lineage of this cell is in order to come up with a diagnosis. So in order to recognize the lineage, you can do that either by morphology. With enough experience, you realize what types of cells these are. But if you want to, we're not sure, or you want to be certain about the lineage, then you can do histochemical or immunohistochemical stains. So if you do, for example, among the histochemical stains, you can do toluidine blue, or you can do Wright stain or Giemsa stain, and they will all show metachromatia. Or if you do immunostains, these cells will be positive for CD117 and for tryptase. So the diagnosis is mast cell disease. And like we were talking about earlier, with Incontinentia pigmenti, there's a range of clinical findings, and the histopathologic findings will reflect the clinical findings. Same thing here. There's a range of clinical findings in cutaneous mast cell disease, and depending on the clinical findings, those will correlate quite well with the histology. In this case, this density and distribution of infiltrate will correlate better with the diagnosis of urticaria pigmentosa. So that's the diagnosis for slide number 4, urticaria pigmentosa. So again, main thing just to emphasize is to recognize the distribution of this infiltrate and then the cytomorphology of these cells, especially the amphiphilic quality of the cytoplasm. See, it's kind of granular, and just the presence of scattered eosinophils, and then you can confirm with immunostains. Very well. So let's move on to case number 5. Here we have a shape biopsy. Oops. Here we go. So this shape biopsy looks quite abnormal. You see marked hyperkeratosis, and then again, this is compact orthohyperkeratosis. There's no parakeratosis. And then the epidermis shows hyperplasia. The basal layer is pretty much unremarkable, but then starting at the mid-spinous layer, and particularly in the cornified layer, you have very dramatic changes. There's this vacuolar degeneration of the spinous layer with cytolysis, with cells appear to be falling apart. And then we have clump keratohyalin granules in the granular layer, very prominent granular layer. So again, this epidermal reaction pattern that is very important for you to learn how to recognize. And it can be very, florid, like you can see here, or sometimes it can be a little more subtle, like you can see here. So there's a range of findings, but you should recognize it. And this epidermal reaction pattern can occur in a number of different clinical settings. If this were to be a biopsy from a baby, and this is a congenital lesion, then this would correlate with the bullous ichthyosiform erythroderma. Of course, we know this result of mutations of keratins 1 and 10. But we can also find this incidentally in a number of conditions, like in biopsies or excisions of basal or squamous cell carcinoma or adjacent to nevi. You have a little focus of epidermolytic hyperkeratosis, and presumably there's like a little acquired mutation of keratin 1 or 10 in a small population of cells that gives you that morphology. But also it can present as a clinically apparent lesion, as a single like a keratotic lesion, like a keratosis. And in that case, you know, we would diagnose this as an epidermolytic acanthoma. And so that's epidermolytic hyperkeratosis. Okay, let's move on to the next case. Here we have a bisected shape biopsy. And let's take a look. So this power, you can see that the main finding is the presence of epidermal hyperplasia, prominent granular layer, and again, compact ortho hyperkeratosis. Remember what we were talking about earlier in the case of ichthyosis, talking about the presence of compact orthokeratosis, how that correlates with a prominent granular layer. So this is what we see here. You know, maybe these are findings that you would expect to see like in Lichen simplex chronicus or maybe an early lesion of prurigo. But in this case, there's something additional. There's an additional finding. So we go on higher power. You can see that there's quite a bit of pigment incontinence, a little bit of solar elastosis. But then we will look at the dermal papilla. We start to find areas like this, where we have pale pink globular material that appears to have little cracks. You see them, right? And these are mixed with melanophages. You have a few of those. You have them here, there. You have them a little bit there. And you have, yeah, so that's the main finding. So in this case, you, of course, you would suspect a diagnosis based on these findings, but you like to confirm it by doing special stains. And so if you do, there's a few histochemical stains that you can do. You can do crystal violet, and that will highlight very nicely. That's probably my favorite histochemical stain for this condition, although it's not widely available in many labs. But you can also do Congo red, and that'll be positive. So by now you know the diagnosis, of course, is lichen amyloid. So this is deposition of amyloid within the dermal papilla. And the difference between, of course, lichen amyloid and macular amyloid is that in lichen amyloid, you have epidermal change like you can see here, with almost like lichen simplex chronicus type change. Whereas in macular amyloid, you don't have any epidermal changes. But going back to the stains, you know, the classic stain that for staining amyloid is Congo red, and the classic description is that if you look at it under polarized light microscopy, you would be able to see candy apple birefringence. The thing is, in my experience, Congo red stain doesn't work quite well in case of macular and lichen amyloid, because I mean, of course, Congo red stain does highlight the amyloid, but when you do the light microscopy, the polarized light microscopy, it doesn't show the apple green birefringes that you can see in other case of like systemic amyloid. So for that reason, my favorite stain for lichen amyloid and macular amyloid is actually keratin, because these are keratinocytic derived amyloid. So it would stain positive for a keratin immunohistochemical stain. So you can do that, and works quite well. So again, that's the diagnosis. Here is lichen amyloid. Okay, let's move on to the next case. This is a great slide. Actually, I must say that I have never made this diagnosis on histology, so I was very happy to be able to review this slide. So the findings here, as you can see, this is probably from the head and neck area. You have hair follicles. Here you have dilation of the infundibulum of this hair follicle, But not only are the infundibula dilated, but also the isthmus of the hair follicles are dilated. We also have elongation of the reedy ridges, as you can see here. And of course, you know that the epithelium of the infundibulum is different from the overlying epidermis in the sense that typically in a normal infundibular epithelium is flat. You don't have reedy ridges. And in here, this infundibula, in this infundibulum, you don't have, I mean, you have more than reedy ridges. You have proliferation or elongated reedy ridges, almost to the point of appearing to be like a little septae with little horn cysts. So again, look at these finger-like projections. You can see again the finger-like projections, and there's also increased pigment within these elongated reedy ridge-like structures. Again, forming little septae-like areas. So the diagnosis here is Dowling-Degos disease. Yeah, those are the main histopathologic findings in Dowling-Degos disease. Again, the dilation of the infundibulum and isthmus, and finger-like projections of the reedy ridges and infundibula, and the hyperpigmentation that you can see. It's really not increased melanocytes, but really just increased melanin within keratinocytes. Very well. Let's take a look at the next slide. Oops. Apologies, technical difficulties. Let's see if that works now. There we go. So here we have another bisected punch biopsy. In this case, it's probably from the back. You can see a very thickened dermis. And then at this power, you can recognize that there's an infiltrate, and the distribution is superficial and deep, very vascular, almost nodular here in the central reticular dermis, and it goes all the way down into the subcutaneous tissue. And the epidermis is there's not a lot to remark on the epidermis. Let's see, one second, what is this? What do you think? We're talking about epidermolytic hyperkeratosis being present as an incidental finding. Well, we have a nice example here of a kind of subtle focus of incidental epidermolytic hyperkeratosis, but don't pay attention to this. That's not the diagnosis in this case. So let's go back to this infiltrate, right? So we already established that it's superficial and deep, perivascular and actually nodular here. And so the next step is to take a look at what are the constituent cells of this infiltrate. And trying to go on higher power. It's a bit frozen, sorry about that. One more try. Yeah, I'm having some technical difficulties. Hopefully this part can be clipped from the presentation. Let me see if I can reopen. 1 second. Okay, hopefully that is better. Okay, so let me start again with this lesion. So here we have a punch biopsy. This is probably from the back as it has a very thickened dermis. And so the first step is to figure out what is the distribution, and this is a superficial and deep perivascular, nodular, and actually even goes all the way down into the subcutaneous tissue. So, and then the epidermis, we can see that it is essentially unremarkable, except for this. What do you think that can be? This is actually, we were talking earlier about epidermolytic hyperkeratosis. So there's actually a focus of incidental epidermolytic hyperkeratosis, similar to one that, to the case that we saw earlier. But this is, again, an incidental finding is not a diagnosis. So to reach the diagnosis in this case, we really have to take a look at this infiltrate. It is pretty dense. And as you can see, it is a mixed infiltrate. It's composed of lymphocytes, histiocytes, and it has numerous eosinophils. So for this case, again, superficial and deep, with numerous eosinophils, one thing you can think of would be an insect bite reaction, except it's a little more dense than we typically have in insect bite reactions. Although there's some clinical scenarios in which you can have something like this, like a persistent insect bite reaction. For example, some patients with a CLL can have an exaggerated insect bite reaction. So that's a possibility here. Except when we see this other piece, we see the explanation why this is such a dense infiltrate. And what do you think this is? These are actually thick mouth parts that are embedded here deep in the reticular dermis. And so that's why this is causing a persistent and very dramatic insect bite reaction with numerous eosinophils. Okay, let's move on to the next case. And let's choose this one, yeah. So this is a shape biopsy that's been trisected. It's cut into bread loaf into 3 pieces. And here you see a pretty symmetric vision, and you have these 2 structures in the cornified layer that are quite characteristic. It's actually a column of parakeratosis. And at the base of this parakeratotic column, you can see numerous necrotic keratinocytes and sclerotic cells. And you also have a loss of a granular layer. See, that's a granular layer there. And then as soon as you start having the parakeratosis, you have absence of granular layer. Both of these findings can be seen on either side. Again, column of parakeratosis, scattered necrotic keratinocytes, and absence of granular layer. So it's pretty straightforward diagnosis. This is porokeratosis, and this is especially easy when you have both cornoid lamella. That's the name for this this finding. When you have 2 cornoid lamellas at either side, then you have a pretty straightforward diagnosis. Sometimes when you have a single cornoid lamella, it can be a little more challenging. But one thing that I found very helpful is that to look at the epidermis between the 2 cornoid lamella. Like in this particular case, this example we were looking at, where is it? Here we go. You can see there is hyperplasia, and there is a prominent granular layer. So that's abnormal, right? Hyperplasia and prominent granular layer, that's abnormal. And let's take a look at another piece, like here. Well, is that the best one? That's this probably better. So you can see again, the cornoid lamella in the center of the lesion, you have epidermal hyperplasia and hyperkeratosis. Whereas towards the edge, on the outside, the epidermis on the outside of the cornoid lamella is normal. It's unremarkable. See? It's not a hyperplastic, and it has a normal granular layer. So this is normal epidermis. So that's another thing that can help you. If you see a cornoid lamella, you can compare the epidermis inside and outside of the cornoid lamella to help you make a diagnosis. And the findings that you can see within the epidermis inside of the corneal lamella can be different. Sometimes they appear to be like actinic keratosis type change. So you can have some atypia, you can have hyperkeratosis, you can have different findings, but the main thing is that it is abnormal compared to the epidermis outside. So that's porokeratosis. Let's move on to the next slide. It's another nice slide. So in here is another bisected punch biopsy, probably from the head and neck area. You have several vellus hair follicles with prominent sebaceous glands. And of course, the first thing that stands out is the presence of this brown, yellowish pigment. But also notice there's also proliferation of cells. And these cells are arranged as nested aggregates and single units in the dermis. And they have somewhat of a monotonous appearance. Round central nucleus. Actually, they look a little bit like the mast cells that we were seeing in the earlier example of urticaria pigmentosa, but these are not mast cells, these are actually nevus cells. So it's an intradermal nevus. Also notice a prominent solar elastosis. But again, now back to this pigment. It looks quite characteristic. Look at the shape, kind of curved, elongated. Let's take a look. Almost look like a banana, isn't it? Or like a sickle in some areas. And it has also a characteristic color. It's kind of brown to yellowish brown, right? And so in the skin, whenever we see pigment, we like to figure out what the pigment is, right? So the two most common types of pigment in the skin are melanin and hemosiderin. So for melanin, we would do a Fontana stain, and for hemosiderin, we would do an iron stain or a pearl stain. So in this case, both the Fontana Masson stain and the pearl's iron stain are negative. So that means that this is not hemosiderin or melanin. So in this case, just based on the morphology, on the shape of these deposits, and also based on the color, then we can make a diagnosis of ochronosis. And many times, this pigment gets deposited also within elastic fibers. So as you know, this is a deposition of homogenesic acid, and it could be congenital metabolic disease, also known as alkaptonuria, or more commonly is an acquired condition secondary to topical overuse of hydroquinone. And so in this case, this is of course an exogenous case of exogenous ochronosis associated with an intradermal melanocytic nevus. Pretty cool case. Okay, let's move on to the next slide. Is again another bisected punch biopsy. And so what are the main findings here? Here we have somewhat of a psoriasiform epidermal hyperplasia, slight hyperkeratosis. And then we also have a superficial perivascular infiltrate. Let's take a look. This infiltrate is composed, there's a few red blood cells, but it's really an infiltrate of lymphocytes only. And yeah, you can see there is psoriasiform hyperplasia, but there is the suprapapillary plates are not thin; they're actually kind of thick, right? And then we also have the cornified layer. If we take a look, we have some parakeratosis, and the parakeratosis is actually not confluent. This is parakeratosis that alternates between para and ortho. And let's take a look here, this other piece. So again, alternating para and orthokeratosis. And look at this. There's also pretty prominent acantholysis present in this biopsy. And yeah, so those are the main findings. So so the diagnosis for this case is pityriasis rubra pilaris. So main things to say about pityriasis rubra pilaris is that you know, many times when there is a when it is difficult to tell diagnosis apart clinically, the same will be true on histology. So whenever you do a biopsy, let's say you're not sure whether it's psoriasis rubra pilaris or psoriasis clinically, on histology, we're going to have the same trouble. Although hopefully we'll be able to help out favoring one or the other. But in this case, I think it was probably more of a classic case of PRP because clinically it has you know, all the features. The only thing we're not seeing here is there's no hair follicle, so we cannot assess the presence of follicular plugging, which we typically see in PRP. And so other things that can help you distinguish PRP from psoriasis, which is again on histology also an important differential diagnosis, is that in psoriasis you would tend to see more neutrophils in the stratum corneum, which you tend not to see here. And also, of course, you have thin suprapapillary plates and telangiectatic capillaries in psoriasis, and not so much in pityriasis rubra pilaris. And of course, the acantholysis is much more of a PRP type of finding rather than psoriasis. Excellent. So we're down to our last case, and thank you everyone for sticking to the very end of this presentation. So here we have a bisected punch biopsy. So this is obviously a neoplastic process. Here we have a nodule in the mid-reticular dermis, and in terms of its architecture, is solid and cystic, right? You look at the lining of this cyst. It's composed of columnar cells in the apical aspect of the lining and somewhat more cuboidal cells at the base. And if we follow the lining, we have some papillary projections. See, some of these papillary projections have a perivascular core. And again, but they have the same lining, cuboidal at the base and then columnar at the apices. And notice that, what do you think that cell is? That's a plasma cell, right? So you have plasma cells, papillary projections, and something also to point out here is that there's no apparent connection to the epidermis. However, the lining in some areas has this stratified squamous epithelium, keratinizing squamous epithelium. So presumably this lesion is in continuity with a hair follicle. And yeah, another interesting finding is this. Well, yeah, that's one of the things. At low power, this appears to be well circumscribed, but then you think, well, what do I do with this area? It's not as well circumscribed, but what do you think this can represent? You have some ductal structures. Some of them are kind of dilated. Some of them are smaller, and some of them again have papillary projections. So some of them have a hyperplastic and then an irregular lumen, as you can see here. And so this is actually, you know, there's some differences of opinion. Some people think this all one lesion. Well, let's first address this one. This is actually a Syringocystadenoma papilliferum. So Syringocystadenoma papilliferums typically are in continuity with the overlying epidermis, so it's a little bit unusual in the sense that it is in continuity with what appears to be a hair follicle. And they're usually in the head and neck area. And so one of the main differential diagnosis is with hydranoma papilliferum, which is the other type of adnexal neoplasm that features papillary architecture. However, there's some key differences. Hydranoma papilliferum is almost exclusively presents in the genital area of female patients, and whereas this is more of a head and neck area. And yeah, typically you don't have the plasma cells in hydranoma papilliferum where you do have them in Syringocystadenoma papilliferum. Also, again, Syringocystadenoma papilliferum have continuity with the epidermis, whereas hydranoma papilliferum do not have continuity with the epidermis. So this here is most likely, or it fits best with either a tubular adenoma or a papillary eccrine adenoma. Those are two names of the same lesion. So tubular adenoma, also known as PEA, or papillary eccrine adenoma, or P. So, and this association is actually quite common. Syringocystadenoma papilliferum and tubular adenoma, you see this from time to time. So some people call this mixed lesions or combined lesions, or some people think actually there's a spectrum. It's one entity that presents on spectrums. So yeah, so those are the main findings in this case of Syringocystadenoma papilliferum combined with a tubular adenoma or papillary eccrine adenoma. Excellent. Well, this is the last case. I hope you enjoyed it. Thanks for sticking to the end, and thank you very much, Dr. Davis, for giving me the opportunity to be the host of this session of the Dermpath Happy Hour. Thanks again.
Want to thank you very much, Martin, for that. And thank you all for attending. If anybody has any questions, please feel free to email education@sagisdx.com or me directly at tdavis@sagisdx.com. See you guys next time. Have a good evening. Thank you.